Good evening, viewers. My name is Rahul Desai, and I hereby welcome you all to our second episode of Hydration Diabetes series. This online module is brought to you by Enazal Zero and in memory of Dr. K.K. Agarwal sir. Viewers, why hydration is important and which are the components of hydration and other factors associated with it. This is very important. And to take us through to today's topic, that is the endocrinology of water, we have our very honorable Dr. Sanjay Kalra sir. And with us today, our speaker is Dr. Saptarishi Bhattacharya sir, who is senior consultant and head of Department of Endocrinology at Max Super Specialty Hospital, Delhi. So before I hand over the platform to Dr. Kalra sir to take us through today's topic and introduce our speaker, let me have the opportunity of announcing the names of those doctors who have answered the quiz questions correctly last episode. And the name, Pratik, slides please. Dr. Vishal Shekhar, Bihar, Dr. S. Pandey and Dr. Sri Prakash Pandey from Chhattisgarh, Dr. Nitin Goswami from Gujarat. We have Dr. I.C. Garg from Haryana. From Karnataka, we have Dr. Ravi Bhatt, Dr. Anupama Swami. From Maharashtra, we have Dr. Shashikant Shende, Dr. Anand Purandre, Dr. Kulbhushan Tandon. From Punjab, we have Dr. Sanjeev Puri and Namrata Puri. And West Bengal, we have Dr. Santanu Kumar Bhattacharya and Dr. Ashutosh Das. So congratulations to the winners. And with this, I hand over the platform to Dr. Kalra sir. Over to you, sir.
Thank you, Rahul, and warm welcome to everybody who is gathered with us today. It's a great feeling being part of this family of Indian physicians, Indian healthcare professionals. We are all working together towards the same goal, which is a healthy country, a healthy nation, a healthy world. There are a lot of issues across the world, and please join me in praying for peace and prosperity, not only in our great nation, but in every country of the world. Now, sometimes the simplest things can be the most important. This is true in medicine, it is true in nutrition, it is true in food. Is it true in beverage as well? And perhaps the answer is yes, because that is why we have this series of 7 episodes prepared for you, in all of which we speak about water. We speak about different aspects, different facets of water. H2O, the simplest chemical formula that you can think of, just H2O, and it packs a powerful punch. Now, when we speak of water, we can speak of the physiology. Dr. Sunil Kota did that for us 2 weeks ago. We can speak of nutrition. Water is a mega nutrient. We'll be talking about that 2 weeks from now. But to do all this, we need to understand the mechanism of regulation. Now, how does the body regulate itself? That is done with the endocrine system, with the help of the endocrine system, with the help of hormones. When we think of hormones, we think of insulin, diabetes. We think of obesity. Perhaps we think of thyroid or gonads, testosterone, estrogen, thyroxine. These are the hormones that come to mind. But let's hold on a second. Does the endocrine system regulate water homeostasis, water balance? Is water a target of the endocrine system? Is water a tool which makes the endocrine system function properly? Let's find out. And to find out the answer to these very interesting questions now that suddenly have come to our mind, we invite Dr. Saptarshi Bhattacharya. Warm welcome, Dr. Bhattacharya. Dr. Bhattacharya is consultant endocrinology at Apollo Indraprasth Hospital, New Delhi, arguably perhaps the most famous Indian hospital, not only in our country, but across the world. He is a star leader of the Endocrine Society of India. And most of the work that has taken place in the past 2 to 3 years in our society, in the Endocrine Society of India, owes its origin, its ideation, its implementation to Dr. Saptarshi. Dr. Rishi, when we speak of beverages, we speak of so many things. Depending upon the season, depending upon the mood, someone like me, I would think of buttermilk and lassi. Other people would think of wine and whiskey. So, how does water come into the picture? And is water an endocrine topic? Do we discuss hormones and water together? I always thought that hormones went along with whiskey and wine.
No, I think it's all related. So whenever you need water, whenever you are having your food or dinner or snack, so you need maybe cold drinks or lassi, or somebody might like wine or beer. So this is something which occurs very very seamlessly. So in our body is so well synchronized, so in most of the time we do not think how so many things are getting orchestrated at the same time, and the same thing is applicable for water homeostasis as well. But when the water homeostasis starts getting deranged, so it can cause multiple problems. So there are acute problems and even there are slow problems, and maybe during the course of the discussion we might have a we might understand that even there is more to water homeostasis, and maybe COVID complications can also be related to water homeostasis because there are molecules which actually link to them. So I think we can start the presentation right now. Can you share the slides, please?
Please go ahead.
Yeah. So a very good evening to all the doctors and friends and seniors and juniors who have joined today. So we will be talking about water homeostasis, regulation of water, and how hormones play a role in that. So Dr. Kalra has already beautifully set the stage for today's discussion. Next slide, please. So what is important to understand is that can I move on to the next slide? Yeah. That water is we will be having a more detailed discussion in the during the next session, that water is a mega nutrient, but it's like an essential constituent of cells, tissues and organs. So majority of our body is actually water. So it's like the earth also, the majority of earth is actually water. So and it's a building material, it's a solvent, and it's a reaction medium. It can be a reactant or it can be a byproduct of a reaction. So it can act as a carrier, so it can act as a insulator, it can act for in the as a lubricant, shock absorber. So there are multiple ways water is intricately related to the physiology and pathology of the human system as well as the animal system. Next slide, please. So, and what is very important to understand is that water homeostasis is very very closely monitored, and there is a very strong homeostasis system which is there, and the water balance over a 24-hour period. So it does not go up by more than 0.2% of the body weight or so. So if it's more than that, then there are actually changes which start taking place, and we will try to understand all that over the next 20 minutes or so. So next slide, please. So how does water enter our system? So obviously it's we know that water we drink or take as along with maybe food. So maybe if even you are having dahi or dal, so it has some amount of water, and that does contribute to the total water intake. So sometimes if we are uh, dealing with a patient who is having a low ejection fraction and we need to restrict water, so we actually calculate these fluids also. So these are also, it's not only the water we drink, it's sometimes the water we eat also which actually play a role in the overall balance of water homeostasis. And it can be produced as a byproduct of various chemical reactions in the body, so that is also a source. So maybe it's not a macroscopic source, but obviously it does contribute to the overall water input. On the other hand, water output occurs through kidney. As we all know that urine is the primary way by which water gets excreted. Also skin, respiratory tract, and even the digestive system, the all this are actually responsible for water coming out of our system. Next slide. So what is very important to understand that this balance of water gain and water loss is very closely very well managed. So it's like, if we are like in an average situation, if we consider the water intake is like 2.2 liter per day, the metabolic production is around 300 ml per day, and the output will be like same amount will actually come out. Otherwise, so you around urine 1.5 liter comes out around through skin and lungs, which is insensible water loss. We do not understand that we are losing water through skin and lungs, but maybe on a very hot and humid summer day, you have a lot of sweat and you do tend to get dehydrated. So even during a marathon run, so some the runners also tend to get dehydrated and they require periodic hydration. So these are situations where we understand that these are important ways actually by through which we lose water, and the total balance of say 2.5 liters, whatever we produce in our body and take in through food or drinks, the same amount is actually excreted by all these four routes. Next slide, please. So now, if we try to understand how the body is responsible for regulating and keeping a very tight balance of water intake and output. So there are essentially this the algorithms always look very confusing, but if you just to make things simple for you, there are essentially three ways by which water homeostasis is maintained. So there are, if you can consider three arms. So one is osmolality, that is, if that is increased, then there are thirst receptors and osmoreceptors in the brain. So there are specific areas in the brain where these receptors are there, and uh, these receptors, when they get stimulated, they cause thirst, they cause avp release. So this is the one primary mechanism, is osmoreceptors in certain areas of the brain, through which thirst and avp production is regulated, and that remains one of the primary acute modality by which water regulation is maintained. And just to think of it logically, the first response actually which occurs is, if you get dehydrated, you feel thirsty. So that is what exactly happens. So the first response which takes place is, if you have an increase in osmolality, you feel thirsty, and the thirst mechanism actually gets stimulated. So that is the first thing that happens when the osmolality increases. That means your body is getting deficient in water, so the blood is getting hyperosmolar. The receptors, the osmolality receptors get stimulated in the brain, and you feel thirsty, and also body's avp production takes place, which tends to prevent excess water excretion, and more water is retained in the body. So these are the two primary mechanisms. So then again, there are other mechanisms like arterial baroreceptors. So if your blood pressure falls, then there are carotid sinus baroreceptors, and also receptors present in the heart. So these two get stimulated. So they stimulation of this, again there is a reflex pathway which sets up the uh, sympathetic nervous system in activity. It makes it more hyperactive, and hyperactivation of the sympathetic nervous system that causes tachycardia, increases cardiac contractility, and that helps to generate maintain the blood pressure. So that is one other mechanism by which water homeostasis is maintained. And lastly, there is the renin angiotensin aldosterone system. So if there is a fall in blood pressure, renin hypersecretion occurs, that causes production of angiotensin 2, that in turn causes production of aldosterone, and that again causes sodium and water retention. So there are basic three essential pathways. One is the osmolar receptors in the central nervous system. Second one, the baroreceptor reflex, and third one, the renin angiotensin aldosterone system, which takes place, which is responsible for maintaining water homeostasis. If we now move on to the next slide, and maybe if we look into thirst, so there are two types of thirst. So one is homeostatic thirst, the one which we are discussing. So if there is a fall in plasma volume, you will feel thirsty. If there is an increase in osmolality, you will feel thirsty. So this is like the closed loop thirst. This is the homeostatic mechanism by which the water volume is maintained, and obviously you might feel you might drink for social purpose. If somebody might be in the habit of drinking along with with his food or meal, somebody might be in the habit of having a large 1 to 2 liter of water right early in the morning. So these are non-homeostatic thirst, and the other one we just discussed is homeostatic thirst. So these are the two primary types of thirst, and both are and homeostatic thirst is the one which is responsible primarily first step responsible for maintaining the water volume in our system. So if the thirst mechanism gets impaired, if somebody is drowsy, unconscious, so these are situations where you actually need to be very, very careful about going into hyperosmolarity, hypernatremia, and related complications. Next slide, please. So again, the mechanism of thirst, as we were discussing, so there are distinct peripheral signs and receptors which stimulate the thirst mechanism. Some of them are situated in the oropharynx. So if you feel thirsty, your throat tends to get dry. So that occurs with decrease in fluid volume. So the receptors which get stimulated, even the GI tract fluid osmolarity also stimulates receptors, the hydration state in the blood, and the amount of water you are drinking. So all these combined together, actually they work on the integrated central nervous system, and there are nucleuses like supraoptic nucleus, subpharyngeal organs. Then there are other osmoreceptors that get stimulated, and when they then in turn activates the thirst mechanism. So that is the primary mechanism by which thirst works. Now we'll have a slide, next slide please, slide discussion about how the AVP release occurs. That also essentially occurs in the same way. So if there is hyperosmolality, there are osmoreceptors in the subpharyngeal organ, organa ventrule, OVLT. Then they are located near the paraventricular nucleus. These paraventricular nucleus have magnocellular neurons, and they project into the posterior pituitary. So stimulation of these osmotic osmoreceptors, they cause release of AVP through the stimulation of the magnocellular neurons. And the next slide, please. That in turn will act on the kidney. AVP, there are multiple effects actually. So it's not only about thirst, where it has a role in maintaining the endothelial function. There are V3 receptors on the adrenal cortex that also gets stimulated by arginine vasopressin. Again, it has a role in liver glycogenolysis, although the primary role is actually on the renal tubules via the V2 receptors. Next slide, please. So when AVP is secreted, so there are water channels which are called aquaporin 2. So there is essentially stored in within the cells. So stimulation of the V2 receptor by arginine vasopressin. So these aquaporins get transported onto the cell surface, and they can actually absorb the water which is present in the renal tubule. So there is a tendency to formation of a concentrated urine. There is decreased free water clearance, and the osmolality which had gone up, and as a response to which the V2 receptor, the vasopressin was secreted, so that gets maintained. So that is the primary function of AVP. But again, all these hormones, so if we study them deeply, it's not about that one hormone, one function. So they have multiple diverse functions, and maybe these small functions sometimes do hold key to very complicated and complex disease processes. The next slide, please. So again, what the second mechanism we were discussing was arterial baroreflex. So there are receptors present on the in the carotid sinus, there are receptors present in the heart. Stimulation of them through and processing through the spinal cord as well as the medullary system, it that increases the sympathetic activity, decreases parasympathetic activity, and helps to maintain and increase the arterial blood pressure. Next slide, please. And so again, it's the neural regulation is very, very important. So this is something like if somebody has an acute drop in blood pressure, so we know that there tends to be tachycardia. So this is the mechanism by which actually tachycardia occurs. Next slide, please. Tachycardia occurs and the blood pressure gets maintained, and renin angiotensin aldosterone system. So what happens if the blood pressure falls? There is renin secretion which occurs from the kidney. Renin then breaks angiotensinogen to angiotensin 1. That gets converted to angiotensin 2 by the angiotensin converting enzyme. So these are enzymes which we all have tried to understand all these mechanisms in the setting of COVID-19. So ACE enzyme and ACE receptors, they do play an important role in pathogenesis as well as in viral entry of COVID-19 infection, that we have very clearly seen. And production of angiotensin 2, that in turn works on the aldosterone secretion from the zona glomerulosa of the adrenals, that causes sodium retention, causes the blood pressure to rise, and the blood pressure, the homeostatic mechanism actually gets completed. So next slide, please. So what we also have learned that it's not only the systemic renin angiotensin aldosterone system, all organs including the heart, they have their own renin angiotensin aldosterone system. So these RAAS pathways are actually responsible, say in a failing heart, they're responsible the um, uh, for the cardiac hypertrophy. They're responsible for vascular damage, so cardiac remodeling. So all this occurs through RAS, and that is why RAS inhibitors have emerged as a very important therapeutic tool for treatment of so many disorders, including cardiac and renal dysfunction. Next slide, please. So even glucocorticoids also play a role in water metabolism. Next slide. The thyroid also plays a role in water metabolism. So almost all the organs, directly or indirectly, they do have an impact on controlling the water metabolism, maintaining sodium and water balance. So what we see is that if somebody is having, say, hypoadrenalism or having hypopituitarism, so many of these patients, they tend to develop hyponatremia, and that is because of the impact of deficiency of glucocorticoid. So there tends to be, so it again, glucocorticoid has a water retaining effect, sodium retaining effect. So if that is lost, so there tends to be the loss of sodium, and that causes hyponatremia. So next slide, please. So there are multiple pathways also in elderly and in infants distinctly. So the water metabolism in a middle-aged man or a young adult, the way it is very seamlessly controlled, that is not always true in the elderly. So they do tend to have multiple problems. So one of that is orthostatic hypotension. So that is a very common problem in the elderly. If they tend to go up, stand suddenly, there is a fall in blood pressure. So these are all because of some of the alterations which take place with age, and also altered body composition that occurs with age. And we need to have a closer look at this situation. So even the elderlies are very susceptible to sodium and potassium imbalances. So we tend to see more often cases of hyponatremia in the elderly. So that is why sometimes we give diuretics like thiazide, and somebody gets drowsy, and we check the sodium, it's around in the range of 123 or 125 milliequivalent per liter. And so, but that is something which is not that common in an young adult. So these are complications which are specific for age. And again, there are complications which are specific for infants, so they also take time for the water regulatory system to mature. Even the kidney also matures over, develops fully. The concentrating ability develops fully over at least 2 to 3 or 4 years. So the infants are also susceptible to multiple defects related to water metabolism. So these are two age groups where you need to be very, very watchful if you are suspecting that there can be an impairment of water metabolism. Next slide. So again, there are serious clinical implications of disturbances in water metabolism. Some of it is well known, like diabetes insipidus. So it can be central or nephrogenic. Central diabetes insipidus usually occurs due to damage to ADH. It can be congenital. So where is it? There is a congenital ADH deficiency, and it can be after a trauma, or it can be after tumor, or after surgery. And traumatic brain injury or surgery actually has a triphasic response of related to ADH secretion. So that is something which is very, very interesting. Maybe we can have a discussion on that someday later. So on the other hand, if there are certain conditions which actually stimulate excess ADH secretion, there is inappropriate ADH secretion, that is the syndrome of inappropriate ADH secretion. So these patients, again, they tend to have hyponatremia. So that is another clinical problem which is or encountered very, very often in clinical practice. Next slide, please. So diabetes insipidus, as we were discussing, there are multiple ways which can occur, and even it can occur due to, there is a very unusual clinical condition called psychogenic polydipsia. So somebody has a tendency to drink more and more water. So it's a very close differential. Sometimes we need to do some complicated tests to understand whether it's central diabetes insipidus or a psychogenic polydipsia. And there are even drugs which actually cause nephrogenic diabetes insipidus. So some of the you just need to be careful in those situations. Even at the time of pregnancy, also there is a type of gestational diabetes insipidus which can actually set in. So diabetes insipidus is a very interesting clinical condition. So it requires a very minute assessment, a complicated way to ultimately set the diagnosis or establish the diagnosis. But sometimes a therapeutic trial with an agent like desmopressin, which is the synthetic analog of vasopressin. So that can actually sometimes clinch the diagnosis. So these are important clinical scenarios which we often face in our clinical practice. And next slide. And that actually helps us understand that water, it's not as simple. It's not as simple as water. So it's a complicated. At least the mechanism of this regulation of this molecule is quite complicated in our system. And even if there is a minor error in that pathway, that there can be multiple disorders which can sometimes be even critical. So with that, I will request Dr. Kalra to now come join back. And if there are any questions, that I will be happy to answer. So should we have the questions first, or go to the quiz directly?
We can do the quiz first.
Yeah. So the quiz number 1 is specificities related to body fluid homeostasis are: A, more body fluids; B, higher water and electrolyte physiological losses; C, immature renal function; and D, all of the above. So the question is, specificities related to body fluid homeostasis are: A, more body fluids; B, higher water and electrolyte physiological losses; C, immature renal function; D, all of the above. The next question, question 2: which patient is at more risk for fluid volume deficiency? A patient who has been vomiting and having diarrhea for 2 days, a patient with continuous nasogastric suction, a patient with an abdominal wound vac at intermittent suction, and D, all of the above. So the choices are: A, patient who has been vomiting and having diarrhea for 2 days; B, a patient with continuous nasogastric suction; C, a patient with an abdominal wound vac at intermittent suction; and D, all of the above. So please send in your answers to this, and if there are any questions related to today's discussion, I will be happy to answer. Over to Dr. Kalra. Thank you.
Thank you, Dr. Saptarshi, for that wonderful talk. And you've mentioned how water, which is so seemingly simple, is interconnected with all our hormones. The posterior pituitary, the adrenal, that is corticoids, glucocorticoids, the kidney, that's renin-angiotensin system, and also the heart. So virtually each and every part of the body is linked to water metabolism, and this is all done through hormones. Dr. Satachi, people from all across the country greeting you and thanking you for your lucid talk and compliment that is coming for you. You are a very euphonous endocrinologist. Euphonous, euphonous endocrinologist. So that's a nice compliment. First time I've heard someone in endocrinology getting that. So thank you for that compliment. Uh, a question from Dr. Sanjeev Puri, that is, how do we monitor urine output in indoor patients? If you have someone on a Foley's catheter, then it becomes very easy, Dr. Puri, to monitor that. But let us say you want to monitor in a timed way, maybe 8 a.m. to 8 p.m., then you will have to empty the bladder first at 8 a.m. and then count from there. Dr. Saptarshi, any comments, any ideas, urine output monitoring in the indoor and also in outdoor patients?
So again, so that is something in outdoor, it slightly becomes cumbersome, but we sometimes do tests for 24-hour urine collection. So somebody is suspected to have, say, pheochromocytoma, and we want to do catecholamines or metanephrine. So what we do is that we ask to empty the first morning urine sample should be discarded. So we start from the second morning urine, and each and every drop of urine should be collected. So even so that is very, very important. And at the so the next day you collect the first urine sample in the morning, and then you stop over there. So that is the way to precisely collect 24-hour urine and monitor and measure the 24-hour urine output.
Would you like to speak about diabetes insipidus, Dr. Saptarshi? How do we monitor a patient who is being treated for diabetes insipidus, clinically as well as biochemically?
So again, so diabetes insipidus is again usually of two types. One is central diabetes insipidus, and another is nephrogenic diabetes insipidus. So central diabetes insipidus, there is essentially a deficiency of antidiuretic hormone. So we are replacing, in this case, antidiuretic hormone by an analog of antidiuretic hormone or vasopressin, which is called desmopressin. So again, it can be given in two ways. So there is a nasal spray, and sometimes we can also use a tablet. So if we are giving a tablet or a nasal spray, so sometimes so somebody might require half. So the tablet usually comes as a 0.1 mg tablet. So somebody might require half a tablet. Somebody might have more of nocturia. So usually we tend to give the tablet at night in most of the cases, because nocturia can be actually problematic. So there are other situations, somebody might require an additional half tablet or one tablet in the morning. So that is, and if you are giving that tablet, what you need to be careful is you need to look into 3-4 states situations. So one is, you should not be under hydrating, you should not be over hydrating. So if you are giving excess, the patient can actually slightly tend to get edematous, or the patient actually can develop electrolyte imbalance, so there can be more fluid, so there can be hyponatremia. If you are under treating, then there is a tendency for polyuria, the person might feel dehydrated. So one is the clinical symptom, you see the hydration status, you see what is the total urine output, you see what is the frequency of urination. So that is obviously the most important step. And periodically you need to check the sodium and potassium balance, and if you are sometimes doubtful, you can even check the urine osmolarity sometimes to assure that whether if there is a genuine doubt related to compliance, or you are suspecting some other cases.
Right. Another question coming from the audience. When we manage other pituitary diseases, let us say uh, thyroid or prolactin related, then we measure hormones. Like we monitor with the TSH, we monitor with the prolactin. Now, if there is vasopressin deficiency, then do we check vasopressin?
So again, that is a very important question, which actually is a clinical challenge. So vasopressin, there are tests to measure vasopressin levels, but vasopressin is a hormone which is very unstable. So if you are collecting a sample for ADH, not many labs in India can actually do that. So it's only in a very specialized situation you can actually measure vasopressin level. So, if you are first of all trying to assess vasopressin secretion, there are two tests which actually become, apart from the appropriate clinical situation, there are two ways which you can actually do it. So, one is a test called water deprivation test. So, if you are not allowing a person who is having say diabetes insipidus and having polydipsia and polyuria, and so if you do not allow the person to take water, so that requires admission, it requires monitoring. So in a supervised scenario, if the person is not allowed to take water and you monitor the weight, you monitor the urine osmolarity, you monitor the serum osmolarity, and once uh, that after a certain time, when you reach a certain threshold that the urine osmolality and serum has actually stabilized, you actually give a dose of desmopressin and see what is the response to further differentiate. First of all, you will first of all understand if you're depriving water, whether the person is able to concentrate urine or not. So the normal response is that the urine osmolality will keep on increasing. So if the person is failing to concentrate urine, then you need to check whether giving desmopressin or vasopressin will actually help to concentrate urine or not. So the most of the clinical tests for diagnosing diabetes insipidus is through water deprivation followed by a vasopressin or desmopressin challenge. So that is the usual way to do it. So but this is a complicated procedure which requires an advanced setup. So there is one molecule which has been used as a surrogate marker for vasopressin activity, that is copeptin. So there are actually many studies which suggest that copeptin, which is measurement in the body, can give an idea about the vasopressin secretion. So so that is another way which you can indirectly measure the amount of vasopressin secretion in our body. So these are the two ways. If there are very few laboratories which actually they check vasopressin or ADH levels, but again in Indian setup, in a routine setup, it becomes a challenge.
So we have surrogate markers, and this thing is not limited just to vasopressin. Even let us say you are giving hydrocortisone or prednisolone to a person with Addison's disease, then we don't check serum cortisol. We have surrogate markers of checking. You can check clinically through well-being. You can also check maybe biochemically through a sodium potassium. So it is not only in vasopressin deficiency that we use surrogate markers in endocrinology. Another question, Dr. Saptarshi, coming from the opposite end of the spectrum, that is, this is from Dr. Bipin Bihari Singh Sharma. He asks about water logging, excessive water. What are the early signs and symptoms, and how do you manage it?
So again, if somebody is, the body's mechanism is usually very efficient. So if you take excess water, so that will normally pass out through the urine. So water logging will actually take place in some sort of disease. It's very unlikely that a normal person will have water logging. So again, it can be because of three, four mechanisms. So one is, if somebody is say having a derangement in kidney function. So if the kidney is not working properly, so if the water which should be excreted is retained in the body, so that is one scenario. The other scenario is the central mechanism pumping station. So if that is failing, so if you are having say cardiac failure, so there tends to be backlog of water in our system. So again, so that can cause congestive heart failure. So there are features of CHF. So there will be crepitations in the lung, the JVP will go up, there will be edema, even you can have engorgement of the liver. So these are again surrogate clinical markers of waterlogging. So even there are other states where there tends to be waterlogging. So you can have a chronic liver disease or cirrhosis that can also, because of multiple alterations, including the albumin, balance which maintains osmolality, holds the water in our system. That can also cause waterlogging. So even hypothyroidism sometimes tends to cause mild edema. So so there are multiple ways. Again, each of these situations will merit in the specified type of investigation and specific and that what type of investigation, what can be the possible etiology, will ultimately depend on the history and physical examination.
Thank you. We acknowledge the questions and comments from Dr. Hansa, Dr. Hitender, Dr. Harbada, and also Dr. Muhammad Ansari. And it's great seeing so much of enthusiasm and so much of participation, even late night. Dr. Natraj ji, Satvik ji, Ajay Kumar ji, and Himanshu Singh, thanks for all your comments. So it's been great having everyone with us. Dr. Satarshi, I'd like to thank you for your time, your energy, and your enthusiasm. And just a very humble, a very personal question, if you allow me to ask.
Sure, sure.
What is your favorite beverage?
Water.
Water. So, on that note, I'd like to thank everyone for being with us. Uh, it's good to learn about hydration because we can actually help our patients. And we do have many medical grade preparations now, which give us a wonderful balance of water as well as electrolytes. If the patient whom you are treating has diabetes, then you have brands like Enerzel Zero, which are 0 calorie, and for others you have preparations with different calories. Enerzel Blitz is one with just 29 calories per 100 ml. That is just one third of the calories that you would see in Coke. And then, of course, the plain Enerzel is there. The Panchu Singh ji has also joined us. So, with this, good evening to everyone. And from our side, I'd like to say good night. And please join us again 2 weeks from now for our next session, which will be on water, the mega nutrient. And I'd like to hand over to Team FDC for the concluding remarks.
Thank you, Dr. Bhattacharya and Dr. Kalra sir, for taking us through today's topic, which seemed very simple, but the content and the depth of the knowledge was on a higher side. Thank you so much. Thank you, viewers, for attending the session, on taking out time in this evening. Thank you. Good night.
Good night.